See so many of you here this morning. So I'm Sabrina Taylor and I'm the Chief Exec here at Healthwatch Nottingham and Nottinghamshire. And I'm so delighted to open today's community pharmacy stakeholder event. We're really pleased to have so many of you with us. And, there's good representation, I guess, from across the board. So there'll be a good range of perspectives from within the health and care system. So that's fantastic. Today is about sharing what we've heard from our communities around their experiences with community pharmacy services. And I guess it's also about creating space for reflection, challenge, some meaningful dialogue. Our hot topic reports are designed to spotlight key issues that matter to local people. And so this latest work highlights both the value and complexity of accessing pharmacy services. I want to thank all of those who contributed to the engagement and analysis that underpins this report, particularly Kinsey and Azra and Richard and all of our wider team. They've done a fantastic job of putting this all together, speaking to lots of people, writing it all up, analysing it all. It's been a really good piece of work. So I encourage you to listen with curiosity, engage openly, and think about how we can act collectively on what we've heard. So I'll now hand over to Kinsey, our Head of Engagement and Community and Projects, who'll set the scene for us around our hot topic work. All right, so enjoy, everybody. Thank you.
Thank you, Sabrina, and good morning, everyone. And I think I would also like to extend the thanks to all our partners and friends and colleagues and supporters who join us this morning. And I also want to say this is the first time that we have conducted an engagement event or sort of online engagement stakeholder event like this after we published a report. And so, yeah, thank you very much for taking the trial and joining us. We will be very much looking forward to how you found it at the end and whether it's something that you will recommend it that we will carry on for every report we publish, or whether we think that actually maybe and it is something that we can dip in and out as we go along. But yeah, absolutely delighted to have you. So I have been asked by my colleagues to say a little bit about what is a hot topic and why we do it. And some of our volunteers and staff around here probably will know, but for the benefit of all of us, and basically hot topic is historically used to be known as question of the month. And as you know, Healthwatch Nottingham and Nottinghamshire has been around now for 11 years and counting. And we started as two organizations and we merged in 2018. But prior to that, we had Healthwatch Nottingham City and Healthwatch Nottinghamshire. And we all have a greater number of engagements and volunteers out and about in our communities, covering across our wider batch. Before the pandemic, when the world was not so virtual, and dare I say, when we had greater resources and kind of a team to go out and about, I think it would be fair to say that we were physically present more. But the issue about the question of the month or hot topic is basically it's hot topic because it's what is a pressing issue. What are we hearing more on at a given time? What is causing concerns and sort of like complaints or issues for people across the board that access health and social care? And as you probably know or may know, and Healthwatch gets inquiries or feedback or questions pretty much on a daily basis. These come to us through different ways and means, including through our website, by telephone. There are two of our staff who are on this team today who diligently every week going through our info account and our telephone messages and sifting through who contacted us and what the message they left for us. We have letters, believe it or not. The last letter we had was from a person in Nottinghamshire. We've got inquiries raised with us at our Engage Hall, the meetings and event when we are out and about. And when we go to community groups, they may raise something that is specific to that particular cohort or that is kind of general to wider population. When we're out and about, we also have a short form that has sort of asked us along the lines of what are the 3 most pressing issues for you in health and social care. And obviously, we know Nottingham and Nottinghamshire are community within communities. Something that matters to a group in Radford in north of Nottinghamshire might not be so much the same in Hyson Green in Nottingham City or St Anne. So we kind of try to be insightful and curious about what matters to a particular group of communities, and as their needs will always be different. And basically every other week, on a Thursday to be precise, myself and some of the colleagues here, we go through the issues that came to us across the board through different ways and in the previous fortnight or the previous 2 weeks. And then we discuss these and we theme those and kind of see if there is a pattern on a particular area or topic. We also decide whether what we need to actually raise with home, because often, believe it or not, about 60% of our time is working behind the scenes and raising issues with our health and social care leaders about the issues that has been raised and with us from the public. And some of those issues may lead to a hot topic, because we might basically realize that actually there are a number of people from different ages and different areas in Nottinghamshire and different groups that are talking about this particular issue. So hot topic in a nutshell is a public survey that is a sort of an intelligence-led. It's something that is being driven by a significant amount of public feedback. And previous hot topics included carers, they included dental care, they have included GP, general practice access, they have included mental health and so forth. And today we are obviously discussing community pharmacy. All of us either have used or will use a community pharmacy at some point. The one before that, it was on NHS complaints handling. Again, the majority of us do use the NHS, well, if it's not all of us. So hot topic is something that is generally applicable either to the whole of Nottingham and Nottinghamshire citizens, or a good segment of it. And the reason we really do is a public survey is usually runs between could run between 8 weeks and 3 months. And it gives a significant number of people the opportunity to participate in an issue that is applicable to a wider community and basically to have their say in health and social care. And you may say, is it always online? And no, it is. We do have a public survey online, but we also share a hard copy of the survey and we post it to people and we distribute always with a self-stamped envelope. So people do not incur any cost in completing these forms. We also go to groups, people who might be struggling to actually complete the survey, and we physically assist them to ready for the answers they have given. We ask people to post to us for free because we provide the envelope that is already stamped, and we kind of try to really to make it as accessible as possible and as widely accessible as possible. It is different from other projects because where there is something a bit more niche and maybe just kind of it might be relevant to a particular group, but it might not be applicable to everyone. Then we do also undertake a different kind of engagement projects, and those might have one-to-one interviews, survey as well, as well as focus groups. So these give us a bit more qualitative and quantitative narrative information and answers that we could look something into a bit more wider. But hot topic is really supposed to be not too detailed. It's supposed to be most people able to participate, and it's supposed to have a wider relevance for significant number of our communities. And the pharmacy we've just completed, the hot topic on the pharmacy came about because when we went through our feedback that comes to us, we realized that actually there were a good number of people across locations, across ages, across areas that were saying something about pharmacy. And we thought actually this would be good to gauge the public feedback and see how people are feeling about it. Generally about 300-400, normally somewhere between 5 and 300, 250-ish, the response rate sometimes it's up to 200, but it's just we give people the opportunity. Obviously completing surveys is voluntary, as we know, but it always gives us a window of about what actually the majority are saying about it. And if you do have questions about the hot topic and how it works, I think we have a good section this morning because we want to be conversational, we want to be kind of interactive, and so that's why I'm not going to take a much longer time on this, but please do note your questions and let us know when we come to that section. And thank you so much for your time and listening.
Thank you, Kinsey. I said we are running ahead of time. I always like that. So I will now pass over to my colleague Asra, who's the really clever one amongst us. And she will talk about the report itself.
Thank you so much, Richard. So I'm Asra Ahmed, and I work as the Data and Insights Officer at Healthwatch Nottingham and Nottinghamshire, and I was involved in running the pharmacy hot topic survey, as well as analyzing the data and writing the report. Like Kinsey said, that we understand that community pharmacies are an integral component of primary care. They're often available at very convenient locations and are easy to access, so they serve as the first point of contact with the healthcare system for many. According to a report from the King's Fund in 2022, pharmacies across England collectively deliver over 69 million walk-in health advice consultations every year. And it was estimated that if it wasn't for pharmacies, then more than half of these people would end up visiting a GP. So this helps us to put into perspective the role that they play in alleviating the pressure on GP practices and on the healthcare system. Now, since we recognize how important pharmacies are in the healthcare landscape, we were concerned when we heard feedback from people and from our volunteers about the issues that they were facing in this regard. The feedback that we heard was majorly related to access issues as well as medicine shortages. And it was coming in the background of pharmacy closures and staff shortages that pharmacies are facing. And we acknowledge the huge amount of pressure that pharmacies are working under. In addition, we also heard about the Pharmacy First scheme, and people were sharing concerns about this. Now, the Pharmacy First scheme was launched in January 2024. It's a fairly new initiative which built on an existing one, which allows community pharmacies to independently complete episodes of care for 7 commonly established clinical conditions. And the aim for bringing in the Pharmacy First initiative was to provide patients with a quicker and a more convenient way to access healthcare and free up GP appointments for those people who have a greater need. So we included the Pharmacy First feedback in our community pharmacy project as well. And our aim was to understand the public experiences about what challenges they were facing with accessing community pharmacies, and also to increase awareness about the Pharmacy First initiative, because the time when we undertook this survey, it was still within its very first year of launch. We carried out this survey from the end of July to early November 2024, and we gathered responses from 284 individuals across Nottingham and Nottinghamshire. The report that we have written is based on the findings from this survey, and we have grouped the findings into 5 sections for ease of understanding, and I will be presenting them one by one. The first section is about accessibility to pharmacies. So we heard in our survey that majority of the respondents have used a community pharmacy in the past year, which once again highlights how extensive the reach of community pharmacies is and how important they are. The analysis that follows is based on the responses of people who have actually accessed a community pharmacy, which is 277 individuals. Sorry, I just read a comment which says the slides are not changing for me. Is that the case for everybody?
No, we're seeing them change.
Right, okay. So would you like to maybe leave the meeting and join back again? Maybe that can try and fix it, Abdul, if I think. Thank you.
There might be, there's also options to navigate yourself. I think you can, there's a little arrow at the bottom. Potentially, if you have that, you can also push the slides along yourself. But
it's all right. Abdul just said it's now caught up with itself clearly.
Okay.
So
Right, yeah, probably some connectivity issue then over there. Thank you, Bud. So yeah, so going back to access, when we ask people how they prefer to access their pharmacies, the most common route was in-person visits for around 65% of the respondents. And roughly a third of the respondents said that they use their pharmacies both in person and online. And this corresponds with surveys and research that has been carried out on the national level. Now, the majority of the people have said that they find it either easy or very easy to access their pharmacy. And only 5% people have reported difficulties in this regard. We tried to analyze further the factors that facilitate access to pharmacies, and we saw that the physical distance of the pharmacy from the respondent's home was the most significant factor, and it was almost matched by the factor which was the attitude of the pharmacy staff. So whenever people felt that they were treated with kindness, respect, and dignity, they preferred to use that pharmacy, sometimes, or even if it was further away from them, as compared to a pharmacy which was closer for them, but where they felt that they were not being treated in the best possible way. This came out as a significant finding for us. Next, we tried to analyze that the people who had expressed difficulties in accessing pharmacies, though the most common reason for them was when pharmacies are open only during office hours from Monday to Friday, they felt that it was very difficult to access. The other factors, as you can see here, are distance from home, parking facilities, and the waiting time that they encountered at the pharmacy. The next set of findings that we wanted to talk about are medicine supplies and the people's experiences with shortages, and which we acknowledge is an ongoing issue across the country. So 36% of the respondents reported facing medicine shortages, and this correlates with national findings from Healthwatch England as well. We also wanted to highlight that many of the people who faced medicine shortages attributed their experiences to national or local supply issues, so they were aware of the wider challenges which pharmacies are operating under. The problems that medicine supplies cause for patients, it has a huge impact on the lives of the patient and has brought about something which is now referred to as pharmacy bingo, where patients have to move from one pharmacy to another and look for the medications that they need to obtain. But it doesn't only impact the lives of the patient. increases pressures on the pharmacy staff and on the GPs. And that was something which was acknowledged by the patients who were responding to our survey as well. The next set of findings talk about the reasonable adjustments for medicine dispensing. And we wanted to understand if medicines were dispensed in a way which meets the needs of people. We intended to include reasonable adjustments here, such as large print labels, easy open containers, multi-compartment compliance aid, blister packs, and reminder charts. For more than a third of the patients, this was the case. Their medicine were dispensed in a way which met their needs, and only 8% of the respondents reported that their needs were not fully taken into account. However, at this point, I wanted to highlight a significant trend that emerged from the data of the past 3 sections. When we carried out cross-tabulation analysis of the responses for a particular demographic subgroup of respondents, we discovered that individuals belonging to the more vulnerable subgroups, which are listed here, are affected more than the average. As an example, more than half of those people with mobility impairments faced medicine shortages, as compared to only a third of all respondents on an average. This is really important because it highlights the disproportionate challenges faced by the vulnerable groups, who often have higher healthcare needs. And this disparity could contribute to inequitable access to medications and widen the gap in health outcomes. So it's even more essential to address, even though the numbers might look small. Moving on, the next section was understanding the affordability of prescriptions. Here we discovered that the cohort of interest for us is of course the 31% of respondents who actually pay for their prescriptions. As we know that all across England, it's only a small proportion, around 10% people who do pay for prescriptions. And in our survey, it was 31%. And a substantial proportion of those reported challenges with affordability. And it makes it quite significant and highlights the impact that the cost of living crisis can be having on medication uptake. The last section was aimed at the Pharmacy First scheme, like I said, and 40% of the respondents had heard about the scheme, which is a noteworthy figure because the scheme was launched in January 2024, and we were carrying out our survey in the very same year. And the public promotion, which includes radio, television, ads, posters, flyers, newspaper adverts, and social media were the most common sources. Others had heard about the Pharmacy First scheme either directly from pharmacies or from their GPs. And roughly a quarter of the respondents claim to have actually tried using the service. And these are the people who we asked to share feedbacks about their encounter. We received a mix of both positive and negative feedback. The Pharmacy First scheme was appreciated for its efficiency and for the ease of access. However, some people had had a poor experience in that they faced increased treatment time due to the need of referrals back to a GP or to an urgent treatment center. And some were disturbed because there were limitations in the age or conditions or medications that were covered by the scheme, and they felt that this increased their time because they were not meant to be treated by it. What we picked up here was that it could be indicative of the lack in public awareness about the conditions and the age groups that are eligible for the service. It was also noteworthy that a few respondents expressed a lack of confidence in the diagnostic abilities and the prescribing abilities of the pharmacists, which was suggested of a potential need for educating the public and for addressing the traditional perception that the role of pharmacists has been for the public. Moving on to our final section on recommendations that we have presented as a part of our findings. The 5 major recommendations have been made, and they are targeted at community pharmacies, the local pharmaceutical committee, as well as the integrated care board to address some of these issues. Our first recommendation is about the opening hours because it has come up as a significant factor in hampering access. So there might be a need to adjust the opening hours to better align with the need of working individuals. The second issue is to ensure effective communication between pharmacists and patients. And this needs to ensure that we are addressing things like affordability. We are making sure that patients are aware of reasonable adjustments that are available for them. And we are supporting vulnerable patients with the needs that the extra needs that they might have. The Pharmacy First scheme, around that scheme, we have suggested that it would be useful to have improved clarity in communication about the scheme and enhance the effectiveness and long-term sustainability. So we need to focus on building awareness about the scheme and also addressing the public confidence and making sure that the signposting is effective to the scheme to avoid the back and forth and not make patients feel that it's taking up extra time to go to the pharmacy first. Our fourth recommendation was communication on medicine shortages and pharmacy closures, where we have recommended that the ICB takes a proactive approach in communicating with the public and the patients about medicine shortages and about pharmacy closures to maintain transparency. The final recommendation is for the need of the ICB to proactively monitor and mitigate the effect of closures, because we know that in England there is roughly 1 pharmacy closing per day. So we have seen that the physical distance of the pharmacies is the factor that facilitates access to them. So that is something that we definitely want the ICB to monitor and mitigate. And with that, we've come to the end of the report. Thank you so much.
Thank you, Asra. We've actually had some discussion already in the chat regarding some of the issues. That we have several professionals here who have awareness of some of the issues. I wonder actually whether in terms of the medicine shortages, which we know definitely has an impact on people, it can cause, if you're lucky, it's just multiple visits, but it can mean, as some people have had, their medication being changed, or in some cases, just a shortage of medicine lasting several months. So I wonder actually if there's anyone here would actually like to comment. Rebecca.
I just wondered whether an example might be helpful, and it's a really hard example. So people who've had pancreatic cancer or have pancreatic cancer may no longer make the enzymes that they need to digest food. So this is really fundamental to be able to get the calories that you need out of food. And we call this medication PERT, and I apologise because I'm going to fall into that acronym, so I'll get it out there now. There is going to be a shortage of PERT until at least 2027. We know that nationally, what is available to come into the UK, because I know in the side somebody's asked about shortages, it's incredibly complicated. It's affected by global markets, it's affected, but I mean, we are just a small player in a big global market, unfortunately. It can be things like a shortage of a particular ingredient that can be affected by a drought somewhere. So there are all sorts of very strange things that you wouldn't have thought of that would affect it. But coming back to PERT, there will be a shortage in the UK till at least 2027. What we know is that the UK is only able to receive 90% of what's required for current patients as licensed medicines. The 10% will have to come as unlicensed medicines. And as the ICB, We are working with secondary care to make sure that that guidance is updated for community pharmacy and GP surgeries to help manage that. And I bring up this example because it is so hard in the sense of that without that medication, these people do not get their calories from food. We know that this is so fundamental and so really, yeah. There are patients travelling across the whole country desperately just trying to get the medicines. There are people reducing how much they eat just to get the medicines. And I bring this example up for you to know that we, sometimes it can feel like the commissioners are far away. We do know how awful that is. I say we are doing our absolute best working within the national protocols. So there's some serious shortage protocols for pharmacists to follow as well. But nevertheless, that doesn't fix the fact that we've only got 90% of the medicine, and that means that 10% is going to have to be found some other way. So I apologise. I just thought an example like that might be a helpful way to see it.
Absolutely,
Thanks,
Rebecca.
Can you just quickly say what your role is at the Integrated Care Board so people know the context?
Of course, I'm really sorry. I'm the Community Pharmacy Clinical Lead for Nottinghamshire ICB. So I'm not actually directly involved in shortages, but as you see, it comes into community pharmacy because that's where the patients see this happening. My role is actually more about community pharmacy services, but it's almost impossible to not get medicine shortages, I think, in anything at the minute.
Thank you. Mike, would you like to come in?
Hi, good morning. Yeah, hi, my name is Mike Jones. I'm the services lead for Nottinghamshire LPC, or Local Pharmaceutical Committee, and we represent all of the 200 and, as of today, 17 pharmacies in Nottinghamshire. That's county, city, and of course Bassett Law. Yes, I just wanted to build really on what Rebecca said. It's an interesting thing. I'm sure I heard you say at the start that this survey was done between July and November, I think. Is that right?
That's correct.
Yeah. I don't know if you remember, but at that time, virtually all the papers, all the news channels were talking about the ADHD medication that was in short supply. Now, I had a personal experience of this with a friend of the family, and they were doing exactly, or they were forced to be doing exactly what Rebecca was saying, travelling from pharmacy to pharmacy. They lived away from home, etc. And it was incredibly hard. And for those of you know, anybody with ADHD, their lives can just fall apart without their medication. And so the reason I note July to November is it would have been interesting to know what were the medications that were in short supply that these particular patients were talking about. But at that time, that was an international shortage. It wasn't just a pan-European, it was an international shortage causing problems and high anxiety. And I guess those people that would have had, if there were any people who were struggling with that medication, they would have been happy to talk to anybody about that situation because it's so painful.
Surely. Asra, do you want to comment?
Yeah, definitely. Thank you so much, Mike, for raising that. And the ADHD medication shortage that you mentioned was a part of the feedback that we had received, which kind of got us to undertake this project. And in the background, a study that we have done, we have recorded some of the news articles as well, which picked up on those experiences as well as the patients who spoke to us. And like you said, that the medication shortages, so some of the shortages that we heard about specifically as a part of the feedback for this survey included ADHD medications. It also included EpiPens and hormone replacement therapy. So they were the three specifically cited medications that came up in more than one instance. And that's the reason why we have put them there in the report and said that these were specific issues that patients had raised. Thank you,
Asra. Anne.
Hello, I'm community and patient representative for the ICB Area Prescribing Committee, and a huge amount of time is spent at the formulary and guidelines meetings, which are held alternate months, on actually trying to source alternatives for the medicines which are not available. The APC website carries a lot of information, right? We do also have other issues that we have to contend with, which is if alternatives are found, are they affordable with what the ICB allows to be spent? So that's another issue that has to be taken into account, is affordability, because the two criteria under which we operate are patient safety and cost effective, and they have to balance out. And increasingly, we're finding that our hands are tied because of cost, right? But it is a huge amount of the work of the technical side of the pharmacists, and also those of us who discuss and evaluate. And we're very well aware. I mean, personally, I'm aware of the EpiPen thing, but yeah. So it's a major issue, and it's an issue which we suspect is not going to get any easier. Yep.
Thank you, Anne. Helen.
Thank you. A couple of points really. Using PERT, or the general name for the drug prescribed is crayon, for enzymes to help people digest food as an example, but I think the principle applies to a lot of other things as well. So Rebecca, you talked about exploring unlicensed medicines, which is interesting to hear. To my knowledge, the shortage of PERT's been going on for a couple of years. It's going to go on for another couple of years. How soon might we see some unlicensed medicine come through, and how might we communicate that these are okay to patients? Because one thing I found is that there's quite a thriving grey/black market on crayon, and it's so serious for those people who need it. I'm worried that they will go and go to the grey market, pay a lot of money for something that might be fake drugs. So I think I know there's a cost to these things, and I know there are a huge cost constraints on the ICB, but we're potentially talking about people's lives here.
May I pick that one up? This will actually fit into just what Anna's been saying as well. Coming to the APC website soon will be some more updated guidance on PERT and unlicensed medicines. You will have they are already being used in GP surgeries. I had an email about it today because community pharmacy have been given via Community Pharmacy England information about how to order unlicensed medicines and what the prescriptions need to say. That is being updated onto the ICB guidance, but that update isn't in yet. But that Community Pharmacy England stuff does go out to contractors, and actually contractors aren't so familiar with the APC guidelines. They use the Community Pharmacy England guidelines, so that information is out there, and licensed medicines are being ordered for this. With regards trying to prevent patients getting things that they shouldn't have, I would suggest that they always get prescription only medicines through a known prescriber, preferably their NHS GP.
Well, yes, but if they can't get them, they go and look elsewhere. That's
yeah. So their GP should be working with the community pharmacy and writing where they can't get it, writing an unlicensed medicine. The guidance hasn't been ratified yet, but there is guidance that will say exactly when that unlicensed medicine it should be used. But at this point, if a community pharmacy can't get the license, they should be talking to their GP surgery about getting an unlicensed.
Thank you, Rebecca. And you want to come in?
Yeah. Can I just add to what Helen and Rebecca have both been saying about the need for alerting patients also, because I have lived experience of having unwittingly overdosed on vitamin D high strength, because little canisters that I bought at Boots, one of them said take one every day, and another one said ask your GP. Well, that's very difficult to do at the moment, but taking one a day was absolutely very, very wrong. I took one a day, and I was violently ill. So I have asked APC to look into that as well. So there needs to be, patients do need to be alerted to the problem that can arise with things that they buy over the counter, which are not GP prescribed. But also, I have to say that my GP would not prescribe vitamin D top strength, nor would my community pharmacy let me buy it, because the GP would not allow him to sell it to me. So, you know, and yet all older people like myself should be on vitamin D supplements. Right. Yep.
Thank you, Anne. Sonal, do you want to come in?
So now,
can you hear me? Morning, everyone.
There we are. Yes, we can hear you now. That's it.
Yeah, I did put it in the chat, but I mean, I'm a patient representative on the Nottinghamshire Healthcare NHS Foundation Trust PPI group, and I also do a lot of other PPI work. So I'm sorry. Oh, I think my camera might be on now. So I mean, I take a lot of different medication. I'm a fairly intelligent person, and even I don't really know what the difference is between and the implications of licensed and unlicensed medicines are. And I think that's one of the like quite a big issue. So people generally, I think, you know, I couldn't really tell you. All I would say is that I think it's whether it's licensed for use by NICE or not. Is that what it is? Or, you know, maybe, and that was also something that people, you know, like needs to be like sort of a message that needs to be made clear to people, I think, is what that means.
Surely,
yeah.
Sonal. I'm wondering actually here whether Mike or Rebecca might actually want to come back on that question of what is licensed versus unlicensed.
I'm happy to take this unless Mike wants to. We're both pharmacists, so both capable of answering that.
Yep. I think, yeah, Mike's happy for you too.
So with regards to licensed medicines, they all have to go through the MHRA. So let's see if I can remember what the MHRA stands for, because we all use a lot of acronyms.
I can help with
Go on,
that. I think it's the Medicines and Health Regulatory Authority.
It almost, apparently Google says agency, but I think
Agency,
authority
okay.
and agency between friends. So the Medicines and Healthcare Products Regulatory Agency. So when a new medicine comes through, it has to go through safety and licensing with the MHRA. So the MHRA will have made some checks and said that this is licensed and safe to be used. This medicine is safe to be used for this particular treatment at these doses. Then unlicensed steps back in two ways. You can have unlicensed use. So we might have a medicine that actually has gone through the MHRA, but not for that condition or not at that dose. And then we're using it in an unlicensed way. And often we have to, perhaps particularly in children, because drug trials aren't often done in children. So that's the problem. And sometimes there isn't enough people for the drug companies to make it worth their while to put through the licensing. And then we've got unlicensed medicines completely. So these haven't gone through the MHRA, and there can be a whole host of reasons why they're unlicensed. Sometimes we call them specials. So they're being made for such small quantities of people that they're not going to, there's just not the money for anybody to license them. So they're being often made for very small bespoke conditions, or they're licensed in other countries and haven't been through the MHRA. So I'm not quite sure I haven't had enough to do with the Creon to know what the unlicensed ones are with regards to that. But I hope that helps. And what we try very hard to only use licensed medicines, because we know then we've got that assurance that they are safe and effective. We know how they've been made. We know that that's all. So we always try and use license where we can. But sometimes they're not available. I don't know whether, and Anne may know better than me, some areas, I haven't been working in the area prescribing committee in Nottingham, so I'd have to go and ask, but some areas have put a leaflet on for patients. I don't know what their workload is. I certainly don't want to make any promises, but I can feed that back.
Yeah, and just maybe if you've got an FAQ, if there's an FAQ section somewhere, you know, on the Health or some other, you know, other websites like that give people information about these things, maybe there would be a good place.
Can I just pick up on that? Sorry,
please, Anne.
sorry,
Yes,
Chair,
please do.
through the chair. Can I just pick up on that and what Rebecca said? Definitely. I work with them on the patient leaflets. They are not the patient leaflets, but the people working on them are very overloaded at the moment. But this is a very, very important issue. And I would take that back to them. And yes, definitely, we need to do that one. And the other thing I would say is that every 2 months, APC, Area Prescribing Committee, do a webinar summarising everything that's gone on in the formulary and guidelines meeting for the previous 2 months. They're intended, the webinars are intended mainly for the trade, as it were, for pharmacists. I go on, but I'm also certain that anybody here for whom today is important enough to come on would also be very, very welcome at those webinars. And what I will do, if you think this is a good thing, I will actually make sure that the invitation also comes out to Healthwatch, and then you can circulate.
Please do. Yes.
Would it be possible for someone to post a link to that on, you know, every time somebody?
Can I just say the links for the webinars only come out just before the webinar, right? So the link for the webinar will come out a few days before the actual webinar, and I will make sure that it comes across to Healthwatch. Is that okay? Does that help? Yep.
Thank you.
Yeah,
thank you, Anne.
Perhaps if it could be, because although the links to meetings are usually just a few days before, what I meant was the link to where to find out about these webinars and things would be really helpful. If people, could I request that, like, when people are mentioning these websites and things like that, that all the links are posted in the chat for today?
Is that who's talking to me? Is it
Sonal?
Sonal?
It's Sonal. Sorry,
That's Sonal.
I can't get my camera to work.
No, that's okay. No. I will. I'll pass all of this back to Laura, the chair. Right. Okay.
Thank you.
Yep.
Thank you.
Okay.
Thank you, Sonal. Helen.
Thank you. Yeah, just taking a couple of steps back from all the comments and discussion we've just had, it strikes me that in a world where we've got medicine shortages, where we're being asked to take more responsibility for our own health, but we can't get through to a doctor necessarily, and there's a shed load of information on the internet, some of which is good and some of which isn't. It highlights the need for really high quality, reliable, good information in a timely manner, not 2 or 3 years after something started to happen, but to help people in the here and now so that they don't get into the position that Anne did, overdosing on vitamin D, and don't start buying dodgy drugs online. I mean, there are some perfectly good drugs online. I'm not, and the processes are perfectly good from many companies, but not all. And it's really obvious that there's an opportunity for people to be taking heaven knows what. But we need timely, good quality information.
Absolutely, yes.
Could I just pick? Sorry, I'm to butt in, but could I just pick up on what Helen said? I was actually told by a JMC GP at the meeting that I should be taking it. So I didn't sort of go online. I'm not an onliner.
No, I take it as well, Anne. Yes.
Yeah. No, but I took it recommended.
Yeah.
And like you, well, I'm not as intelligent as you, but as Sona said, I'm reasonably intelligent, and also shamefully a member of APC, so I should have known better. But anyway.
Thank you, Anne. Rebecca.
This might be a bit of a plea. I don't know whether this is something Healthwatch can help with. I've just put in the chat some information from nhs.uk that does cover this information. And we do nationally have that nhs.uk website. And there's a huge ton of information on there. So even if we haven't got it locally, actually, there's national NHS information. And I just wonder whether that might help some of our, help some of our population, raising awareness of the fact we do have national and an nhs.uk website.
very good point, and I think, I mean, I'll call on Sabrina here to say this is something that potentially we could promote through social media as well, to try and actually give people better access to this information. It's true, if you've used the NHS website before, you tend to know that there's a lot of information there. Even then, of course, finding the information exactly that you want can be a challenge, because there is so much information. But I think that's definitely something that Healthwatch could look to try and help people with. I could be cruel here and actually call on Mosina and say, actually, do you feel that this is something that social media could be used for?
I think so. I think it'd be good to have that information there in a digestible, accessible form, and I think social media is a good medium for that.
I should explain, Mosina is our new comms officer, so thank you. I think we've kind of gone through quite a lot of the questions which people had posted in the chat, and I realised that that we've kind of moved on almost to our question and answer opportunity here. I just wondered if at this stage whether any of our professionals here might want to add anything more from their perspective around some of the recommendations that we've made, in terms of I'm absolutely confident that everyone would love to implement them all, because nobody wants to run bad services. But in terms of actually your insights, I think that would be valuable. Rebecca. Oh, you're on mute, Rebecca.
I'll pass to Mike to give him his opportunity first. But could we share that last screen with recommendations so we don't miss any? Would that be okay, please?
Yes, of course, Asra.
And then I'll wait after Mike.
Thanks, Rebecca. So I think before I come to the recommendations, I just wanted to pick up on a couple of things from the mixed feedback about Pharmacy First. Because I understand my role is really to help and support community pharmacists across the county and city to implement, to be the best that they can be, and implement the national services primarily in a really robust way that helps patients. So the first point I'd like to make is we have to remember that this survey was done in July to November, when the service has only been up and running 5 months. So the majority of pharmacists were, if you like, coming to grips with the biggest change in pharmacy services that community pharmacy has ever seen. And we have to remember that this was supported by £635 million to supply prescription-only medicines using patient group directions, with the ultimate aim of reducing, increasing the number of appointments in GP surgery and reducing the number of extra visits that patients make to hospital. So am I surprised that there was increased treatment time due to referrals? Absolutely not. Because patients and GPs who refer, and by the way, only 1 in 5 GPs refer in Nottinghamshire, despite our best efforts. Increased treatment time is because GPs and patients were getting used to the whole process. And I know from the job that I do going into surgeries that patients who were referred into community pharmacy, sometimes they were referred inappropriately, sometimes the pharmacist couldn't deal with them, and therefore they were sent back to the surgery. So you end up with a bit of a circular loop of care, yeah? So I'm not surprised. The one thing I would say is now, this has been going on now for over a year, and 90%, this is what the survey said, 90% of all patients who have had a consultation and been dealt with through Pharmacy First have been delighted with the care and the service that they've had, and that's ended the care at that point, and they haven't been sent back. So I think that's an important point. The limitations of age, conditions, medications covered, frankly, I think pharmacy finds that frustrating because there are age restrictions. So, for example, we can't treat a male with a urinary tract infection. That is not within our gift because it's not part of the remit of the patient group direction. However, what we have tried to do as an LPC is do our level best through our social media, through our the work that we've done to produce materials for our pharmacists, for leaflets, for posters, to actually get that across to patients. And I would say things are definitely have improved in that space as well. The third point about lack of confidence in pharmacists just becomes from ignorance. It comes from ignorance of what a pharmacist is and what a pharmacist does. And I've heard that myself. And again, I'm not surprised about that third element. When you go back to one of the graphs that you showed about so how did patients understand what Pharmacy First was and where did they hear about it? And basically, as you remember, 40% of those patients were actually had heard about Pharmacy First. So for me, that's 2 thumbs. Magnificent. I guess what I'm trying to say is that came about primarily because of the work that NHSE did nationally in February 2024. Yeah, that national campaign hasn't really happened in that way since then. And there is a big job of work to be done about convincing our patients that we can actually do services really well. And you just look at the way that pharmacies stepped up for flu and COVID, magnificent. So for example, in City, there's no GP signed up to do COVID vaccinations this time around. This spring, it's all been done by pharmacy. So patients are getting more and more used to pharmacy doing this. And I would say we have definitely moved on from this place. The added cost, I have no idea where that comes from. It doesn't cost anybody anything if the patient doesn't pay for their prescriptions. So I wanted to kind of say that first, hand back to Rebecca, and then I'll come to the recommendations, if that's okay.
Absolutely. Rebecca.
Thank you. So I just think sort of building on that about Pharmacy First, I think one of the confusions that happens is, and I've seen it in the press, they talk about community pharmacies prescribing these antibiotics, and actually they're not being prescribed. They're being done under something called patient group directives, which are very strict legal protocols that say who can and who cannot. And I think that's really confusing for patients. I mean, I think PGDs have their place. But I think when we use, and I'm quite picky when I'm doing patient information now about this, I always make sure the word prescribed's not there because I don't think that helps. We do have, by the way, 4 sites on a trial doing independent prescribing, but that's a separate thing entirely. So just running through these opening hours, there's something about quite interesting about the opening hours because there's a mandatory pharmaceutical needs assessment that has to happen in Nottingham and Nottinghamshire, and I know that Healthwatch will be aware of this because actually there's attendance. It's been really interesting because the latest P&A shows that in each area there is a pharmacy with these extended opening hours. So I'm not quite sure what that one's about. I mean, I can reassure that it is kept an eye on, and it includes, with the pharmacy accessibility and location that is picked up in the P&A. And when a pharmacy closes or anything changes, the board have to consider whether a change is needed on the P&A. So that is done. With regards to changing opening hours, that's really hard because actually there is a national pharmacy contract. And we're kind of stuck with that. We are stuck with that in the same way that there's a GP national contract. However, in the latest contract, there is talk about changing legislation, allowing pharmacies to have more flexibility about their opening hours, because we've got a bit of a problem here. They're a business. So, of course, they're not going to be open for one person that might turn up because that's not going to be financially viable. And we know that the average pharmacy is losing £67,000 a year. That was one of the House of Commons reports. So they need to be financially viable. So I think what I'm saying about opening hours is that things are changing. There is some legislation allowing more flexibility. I think we've got to watch and see how that works out. But we do have a pharmaceutical needs assessment. It is only just, in fact, it's just out for consultation now, the new one. So that, there is a handle on that, and that is being checked. I would agree about effective communication. I don't think there's any line of work that you're in where more communication wouldn't be helpful. Nobody's ever said, oh, let's not talk as much. There are, as Mike said, we had the National Pharmacy First stuff. We are locally fortunately, you need money for targeted social media, but we did have a little bit. So there was some targeted social media quite recently about Pharmacy First, where we actually had conversations with patients and explained some of the things like PGDs and things like that. Reasonable adjustments. We've got some information.
Sorry, Rebecca, what's a PGD?
The Patient Group Directive. Yeah,
mindful
sorry.
of acronyms, if they can be avoided, please. Thank you.
Oh, I apologise. I thought because I'd already said what one was, I was all right, but you're
Sorry,
right.
I missed it. Thanks.
No, but maybe that's the point, isn't it? There's too many acronyms. So Patient Group Directives, those are those protocols that Pharmacy First is based on. So with regards to reasonable adjustment, we do have some information about different things that might be helpful for patients and their pros and cons, because there is a problem with many people thinking that a DOSIT box is always the way forward. And actually, they have some really serious problems. When a medicine is taken out of its original packaging, it starts to decompose. That may mean at very best it doesn't work properly. At very worst, it could become harmful. So it's not always straightforward about what should be used. I also think with reasonable adjustments, there is often some confusion over the equality legislation. So reasonable adjustments varies depending on the size of the business you are. So, for example, take an example about a building and a need for wheelchairs to get in. If you are a big company making lots of money, it may be reasonable for you to do some building works and that expectation to be there. On the other hand, if you're renting it and you're barely making ends meet, actually a ramp that's wheeled out is probably more reasonable. And this is the same in pharmacy as well. So, those kinds of effects do come into it. I think Pharmacy First, Mike's pretty much picked up. So I think I'll leave that one around. Communication on medicine shortages, really tricky. We have tried to put some basic information on the ICB website about always if you can't get your medication, please speak to your pharmacist for advice, please speak to your GP for advice. I understand that is really just a first step, but it is a really difficult area to get right, and also within the capacity that we all have. I don't have the magic answers, but we are aware, and we've started that first step. Pharmacy closures are hard because if a pharmacy closes as an emergency, it'll be that date and there won't be time to get the comms out. There is a legal process they're meant to follow, which there should be a sign up in the door and that kind of thing. So I think that's, and there was also, wasn't there, cost of medicines. Unfortunately, I know that it looks like community pharmacy because that's where the payment's taken. But actually the cost of your prescriptions is set by the government and it's not set locally. We do encourage community pharmacists to make people aware of things like prepayment certificates. And in fact, that's gone out in the latest community pharmacy newsletter that went out, which is if it hasn't gone out today, it should have gone out. It's certainly been asked to. So I think that's most of those picked up. I don't know, Mike, whether you think there's anything that needs to be added there.
Thank you, Rebecca. There were just a couple of things I wanted to say about the recommendations. This thing about pharmacy closures is really interesting because just to give people context of how hard this is. So I'm going to just talk. Rebecca's right in terms of short-term closures. That is monitored by the ICB on a regular basis, and if a pharmacy has to close, for example, if a pharmacist has to leave the premises, then everything stops. The pharmacy has to close. That's the law. Now, if they leave the premises, the pharmacy closes, and they have to report that to the ICB. So there is a feedback mechanism for that type of closure. We don't, and it happens. You know, if a pharmacist has to leave the building and go and deliver something, and there's nobody else to do it, it happens. So that's that one. The other one about pharmacies closing for good is a really sad and painful reflection of where we are with the pharmacy remuneration. Rebecca's mentioned the £65,000 loss a year average in a pharmacy. I've had a conversation with a couple of people within the ICB to see whether there's any way we could actually pick this issue up on the back of this report. And what's really hard is if a pharmacy closes, they haven't got to tell anybody that it's closing. It would be lovely if there was a requirement for a pharmacy to say, look, I can't continue my business any longer. I'm giving you 12 weeks notice and that I'm closing. What that would do, it would flag to us as an LPC. We could start to have conversations with the pharmacies around them, because not only does it have a disastrous effect for patients who were serviced by that pharmacy, the impact and effect on the remaining pharmacies is just so critically, it's so painful, because suddenly, if they've been dispensing 1,000 items a week for somewhere, for example, they may all go to one pharmacy instead. That pharmacy falls over. And so you end up with this domino effect. And actually, I know patients don't need to know this, but I think as a result of this report, you do. We understand it, and we as an LPC, if we know anecdotally that a pharmacy is going to close, we can prepare ourselves to then have helpful conversations with the remaining pharmacies to say, this is how you can cope with it. And it isn't easy, and I can't promise that it's going to be a miraculous change at all. But I can tell you that there are thoughts going on about how we can help and support patients through that. So that's really the only additional thing that I would say with that.
Thank you so much, Mike. I just wanted to come in at this point and say that what you picked up around pharmacy closures is what we wanted to address. I'm sure, sorry if the shortened recommendation because of the PowerPoint slide has not made it clear enough, but that's what we wanted to say, that when pharmacies are closing permanently, that can have an impact on the patients who are using it. And I think you picked it up beautifully. And one more thing that I wanted to point out about reasonable adjustments that Rebecca was talking about, and because that's something that comes through when we read the full report, and I understand that this is just a very brief version here that we're looking at, is that when we're talking about reasonable adjustments, it's not only the reasonable adjustments which the cost of which the pharmacy has to bear, but a lot of times things that are available for patients, but they might not know that they exist. Simple things like, aids that can help you pop pills out of packs, because people say that it becomes difficult for them with aids. So it is that they might be able to afford it, but they do not know that simply that something like that exists. Large print labels. So a lot of people, when they read our survey, they said, oh, I never knew that it could be done, that, you could request for the print label on the medication to be a bigger size. So those are the kind of adjustments that we also wanted to talk about, not only the ones which come with a cost, but some of the things that can just be helpful for patients, if that can help put it a little bit more in context. Thank you.
As always, people don't know what they don't know. And that's one of the and actually that is part of the effective communication one, because this is in part why people choose the pharmacies they do, is because you've got good pharmacists and good pharmacy technicians who are really good at actually communicating this is the help that's actually available for you. So I just thought it was worth mentioning that. Sorry, I realised we've kept people waiting for a while. Helen.
Thank you. Yes. Well, I started off with one comment and I've got four now. Just to sort of coming on a number of things, Rebecca, you mentioned the recommendation about opening hours, and you're absolutely right. There is always a pharmacy open somewhere, but just link that back to what patients are saying, that they like to go to the nearest pharmacist, and I think that's what we're kind of picking up there. Because remember, this is the patient voice. There's lots of reasons why things are as they are, and there's lots of things that we can't necessarily fix for patients, but this is what the patients are telling us. And that's another one, I think, picking on what Azra said about reasonable adjustments. I'll just add to that. It's not just that people particularly suffer as patients don't know, but the carers of people don't necessarily appreciate either, and carers don't necessarily think to ask, and it's not obvious always that they may be caring for somebody who's got a particular need. I wanted to say to Mike in particular, again, this is what the patients said to us. I think I've made this presentation to a few groups now around South Notts, and actually, I think, and I represent Healthwatch as well. The view from Healthwatch is that given the amount of time that Pharmacy First had been running when we did this survey, actually, it was pretty much a job well done. Because it is a big change. It is an awful lot to go through, and there's things about communication, which is what I always end the presentation with. But actually, the foundation stones are looking pretty good there. We felt from a pharmacy point of view, and pharmacists seem to have a kind of a better feedback from patients than perhaps GPs and certainly dentists do. So it was a bit of a well done, not a sort of a barrage of criticism. But the last thing I'm going to say, because this is going to be really controversial, and hopefully we'll run out of time if people talk about this one. But I was at a presentation on Monday night about total triage in GP surgeries, and one of the comments, whatever you might think about total triage, was that actually it might make it easier to signpost people or send people to Pharmacy First and to pharmacists. Well, that was the view of GPs, Mike, because they'd have a better understanding of what the patient need. We won't know until we try it, but that's what's being communicated to patients.
Do you want to say something on that? Yeah, please do, Mike.
So the reason I'm shaking my head, sorry, Helen, I do apologise. My non-verbals do give me away a tad, which is worse when you're online. Anyway, these triage systems, it's like the Wild West. And I'll tell you why it's like the Wild West, because there are no standards for triaging. So let me give you an example. Eastleigh. So this is Beaver Health Group. In Eastleigh, we have a pharmacist independent prescriber in the pharmacy that's literally adjacent to the GP surgery. And the GP surgery were referring beautifully into the pharmacy. And Emma, the pharmacist, was dealing with all of those really, really well. They put in a total triage system, and what happened was the referrals dropped off instantly, because the triage system does not say go to your pharmacy first. Nobody thought, when any of these triage systems came in, to put a line in there that says effectively an algorithm that follows the patient's symptoms to go straight to pharmacy. Doesn't happen. Nobody's built it in. There is no national standard. And what we're seeing with these triage systems is they're decimating referrals across England as a result of that. So whatever GPs are saying to you, what they don't really understand is the referrals have always been done by their reception teams, not the GPs. So they're not close enough to it. And so when these triage systems come in, it stops referrals. So I'm quite nervous about these systems for whatever reason. Nobody seems, from Region or ICB, we can't get into these suppliers to say, we need you to make a difference, so that the systems have an algorithm to point people to pharmacy if that's where they should go. Because if it did that, it would be amazing.
That's a terrific insight, Mike. Thank you very much for that, because I think we can push to get some quantification. So how many people were going to pharmacy first before, and how many are going now? You need to fix it. Evidence-based decision making.
Absolutely.
Right. Thank you both. I'm gonna give Anne her chance here because she's asked a favour if she could jump in now. Unfortunately, you're on mute, Anne.
Right, on mute. So sorry, I've managed after about 6 months to get a phone appointment with my GP, so I'm going to have to go. Sorry. Yeah. I had three points, well, 4 points to make. One about communication. I agree with everybody, and I'm actually one of the. I have a team of people helping Notts University pharmacy students in their 3rd and 4th years to develop their communication skills. So that is that we are contributing. Secondly, I am my community pharmacy, for whom I have a lot of respect and admiration. They are not part of Pharmacy First. I asked them this morning. I checked. And even if they had enough money, they wouldn't be able to do it. So, Mike, it is Westdale Pharmacy on Westdale Lane. They need your help, right? They're fantastic people. And then the other thing, when I communicate with my pharmacy, I do it by phone. I don't do it online or in person. I do it by phone. And I have been advised by them to do it on a Sunday morning when everybody else is at church and I'll be able to get through. But I actually managed this morning anyway. That was that. And I think there was something else, communication skills, Notts University, pharmacy. No, and I have recalled all the links and I've written it all down. And thank you very, very much for a very stimulating, very rewarding way of spending an hour and 20 minutes. And bye-bye.
Thank you, Anne.
Thank you very much.
Take care.
Thanks a lot.
I'm aware we are running out of time. Kinsey, can I bring you in here at this point? That's it. It's not a proper meeting if someone isn't on mute when they start.
Thank you, Richard. I think since I put my hand up, a number of the points have actually been either sort of addressed or discussed. But I think the first thing I would say, if anybody takes anything away from this morning, about 50% of the feedback we get is about communication. You can say exactly the same thing to the person and it can be taken in different ways, so it can have the different impact. So, Mike said the fact that the public doesn't have confidence in pharmacies is to do with the public's ignorance. That is true, but what is the remedy for that? Effective communication about what pharmacies can and cannot to do. So I would definitely say, I think effective communication is really, and timely communication is really important, because all of the recommendations we made, that communication is a running theme or it's a running thread. So I will definitely say, let us all try to communicate more effectively and more timely. And one other quick point I would make, and I think Mike alluded to this or actually stated, it's really interesting because when I call my GP surgery, I normally listen to about 5 minutes telling me all the things I can just go to my pharmacy and they will be able to prescribe and I don't need to go and see them. But we also have GPs who said to us, as in the capacity of Healthwatch, that people need to be referred by a GP to a pharmacist for them to prescribe. So I think there is definitely some degree of confusion and it's definitely clear communication needed as to whether somebody needs a referral from a GP to go to a pharmacy to be prescribed, or whether anyone Joe Blow can walk into a pharmacy, and if one of the things they are coming in is within those 7 prescribed list, then they can be prescribed by the pharmacy. And maybe Mike will have the answer magically right now anyway, but even if you do, communicating with the public about it would be fantastic.
Mike, if I ask you to come in quickly yet, this is...
Yeah, 100%. First thing, we're doing a video with a pharmacist in Newark around what does a pharmacist do? Okay, day of a life. This is what the pharmacist does. If you could put that on your social media when that's done, that would be magnificent, because I think that would be very helpful. the Kinsey, I'm really sorry about this. It's this technicality of supply and prescribing. The pharmacists are not prescribing the medication. They are not prescribers. So if a patient comes in and they cannot be seen under the patient group direction, they have to be sent to the GP. So if we can use the word supply rather than prescribe, that would be helpful.
Yeah. Yeah. Thank you, Mike.
Sorry, I know it's technical.
Yeah, no, that's, I'm aware we are really running out of time. So can I ask Margaret and Abdul if they could be quite quick on their comments, and then I want to bring Sabrina in. Margaret. Oh, we can't actually hear you, Margaret.
Should we go to Abdul while we wait for Margaret's sound to come back?
Yeah.
Yeah,
Abdul,
yeah, no problem. I just want to pick up what Mike just said about triaging. Helen kindly sort of delivered this speech to us on Monday at the surgery, so that was really brilliant of her. Triaging isn't about just algorithm based. It's the surgery that we're proposing that we do this triaging. They will actually employ a doctor. And the whole point of triaging is for an online system to be able to get down to the final bit where the doctor doesn't need to ask you numerous questions. He just actually ends up with one final bit at the end. He says, right, okay, now make an appointment, go to a pharmacy, go to pharmacy first. So things are actually developing. It's not quite algorithm based or, in fact, machine learning, because like you say, there is no standards. Secondly, I just wanted to quickly say that online pharmacies are actually on the increase. And a lot of the stuff about accessibility, opening hours and pharmacy first, you can achieve a lot of that. And that's something that we all really ought to look at.
Thank you, Abdul. Margaret, I was wondering whether if you're having difficulty with the sound, do you want to just type it into the...
Yeah, we still can't. I think there's some problem with your connection, Margaret, in terms of, because it doesn't even show that you're muted. So
yeah, I apologize then, Margaret. I will hand over now to Sabrina to wrap us up.
It's frustrating when the text doesn't want to play ball, isn't it? But yeah, if you do want to say anything in the chat, Margaret, please do go ahead and do that. So yeah, I mean, what an interesting conversation, really. I think it's been very, very interesting to listen to all of the different comments and viewpoints. And it's clear, I think, from the discussion that, community pharmacies are playing a really critical role, aren't they, in primary care? And, there are strengths and significant pressures in the system. So it's important to acknowledge that. I think the findings provide some valuable qualitative and quantitative insights into the experiences and expectations and concerns. And it's really, I guess, helping us to highlight some of the themes and issues and potential areas, isn't it, for service improvement that might not emerge through other channels. So I'm really, really, really proud of this report. And I'm so glad that we're able to share more about how we did it and what we've learned. I think, in short, the data may not tell us everything, but it does tell us something important, and that's what matters really when aiming to kind of amplify the voices of service users and communities. So, as our role as a Healthwatch, we really want to make sure the voices of patients and the public drive those improvements in care. And we hope that the insights shared today support your ongoing work, really, and your decision making around it. I hope it's been a useful session. I hope that you've really managed to take something away from this. And that we continue the dialogue, we continue to have this conversation. Our door is always open, as always, for further conversations and collaborative kind of problem solving, really. So, a final thank you really from me as the CEO to everybody who has contributed, who's filled out surveys, who has supported the development of the report. To you, all of our stakeholders, and for showing up really with interest and commitment today. So thank you, and we look forward to continuing our work together.